Okay, I think we're going to go ahead and get started. Again, I'd like to welcome everyone to the Value-Based Care for the FQHC webinar series. Today's webinar we'll be talking about interoperability and using that as a strategic weapon for value-based care. Again, I'd like to take the time to thank the sponsors for this webinar series, the Ohio Association of Community Health Centers, Insight Health Systems, as well as our gold sponsors, Cardinal Health and United Healthcare Group. As I mentioned, this is the third part of a 5-part webinar series. We had 2 excellent presentations. The first one was on quality measurement and reporting by Dr. Lynn Hawley. Last week, Randy Runyon gave a great presentation on payment reform models. And next week, Dr. Ted Wimslow will be talking about patient engagement. So we're very excited about this webinar series. For anyone that wasn't able to attend, the webinars have been recorded and are available to everyone. So if you can reach out to us, and we'll make sure we can get you a copy of that. So for the agenda for today is, again, talking about interoperability and how it applies to value-based care. This is what we're going to go through. I'm going to start with some introductions and backgrounds of myself. We're going to talk about some key lessons that we can learn in healthcare that have been applied from other industries. And then we're going to talk about exchange versus interoperability versus information sharing and how that applies directly for value-based care. And then lastly, we'll talk about various approaches for interoperability and then some recommendations that hopefully you can take with you and begin acting on. Again, my name is James Patt. I have the pleasure to be presenting to you today. I'm the Chairman and CEO of Insight Health Systems. We're a health innovation company headquartered here in Dublin, Ohio. By way of background, my background is about 25 years in the information sharing space. And I've had the pleasure to work across a lot of different vertical industries. Started out in the financial services side, spent a lot of time working with Global 100 companies, both in the areas of supply chain and electronic commerce. I'm a serial veteran entrepreneur. This is actually my 3rd business. First business was focused on enabling information sharing in the pharma and healthcare space. And I spent about 10 years working on interoperability systems and information sharing programs with national security, both at the federal, state, and local level. So quite a bit of experience. I also was fortunate to be able to serve on the board and chair the strategic planning committee for an organization called the IGES Institute. And the IGES Institute is a key association that was designed to promote national information exchange and interoperability. And over the last 25 years, I've consulted with hundreds of small and large businesses and government agencies in helping them develop interoperability strategies and operationalize those strategies. Again, key lessons learned. The problem that we're facing right now, or the opportunity that we're facing right now in healthcare, obviously isn't new, right? So again, over the last 25 years, we've been solving the same problem, just in different vertical industries. And the goal and the mission for everyone is the fact that data today is all around us, and it's spread across a lot of disparate platforms, different systems, different types of users, different levels of sophistication for those users. And the common goal, again, irregardless of the industry, has always been how do we get data that's spread across all these different systems, which in itself is just passive data. And how can we collect that data to become more active, so transform that data into information. And then the ultimate goal is to take this information and be able to gain insights and do things that are prescriptive that we can take action on, right? So again, regardless of the industry, the goal has always been the same. Let's take data, make it into information, and draw key insights from that information that can help improve either our bottom line, grow our top line, whatever, help us meet our business objectives and requirements. So that being said, there's a lot we can learn in healthcare. And again, just taking looks at playbooks and some successes and failures and from past vertical industries. Again, the good news right now is there's proven models out there that we can learn from. Okay, so some examples here. If you look at financial services industry, right? In financial services, consumers, we can use our ATM card, and we can be in a totally different country, and we still can have access to our financial information, gain access to funds, and transfer funds. Right? Again, on the financial services side, as consumers, we may have multiple banks and mutual funds, insurance accounts, and so forth. Each of them are separate, but there's programs such as Mint.com and Quicken that allow us to create a single unified portal so that we can configure our accounts and have one portal to gain access to all of our financial information that's spread out across different financial institutions. Right. In contrast, in the healthcare space, obviously, it's difficult for the patients can't easily organize, access, or share their health data. Right, as easy as we can on our financial side. Also, patients have to deal with multiple individual patient portals. Right, so there's this patient portal overload. Again, from the financial services side, we know it can be accomplished where we can unify those portals, and we know it can be accomplished where we can make the information more freely available to ourselves and for sharing purposes. Right? If you look at examples on the corporate 100 supply chain and the e-commerce side, right? In the commercial space, companies can electronically exchange business documents such as purchase orders and invoices and advanced ship notices with thousands of their suppliers and customers, irregardless of which business system each user, customer, and supplier has, and irregardless of what level of technical sophistication each user has. Right, so a lot of these global 100 companies deal with very large companies with very large sophisticated systems, but many of them also have many small mom-and-pop suppliers or customer suppliers that it's very difficult for them to make those investments in technology and build an infrastructure, yet they've been successful in overcoming some of those challenges. Again, great things we can learn from. Right. Also on the corporate 100 side, companies have evolved from these large monolithic business systems, centralized approaches. You know, it's referred to as ERP systems, which are, you know, let's just take let's find one vendor that has the most comprehensive system. Let's spend a lot of money and a lot of time to implement those systems, and that was a big approach for several years on the global 100 side. And what we've seen is that's moved from these large monolithic business systems to more of a specialized best-of-breed system that can easily connect and interface with each other via web services. Right, so it's being able to pick best-of-breed applications that best meet a purpose and make sure that those applications can talk with each other. Right, so that's what's happening in the Global 100 side. Again, here, as it relates to healthcare, it's difficult for providers to effectively and efficiently share health information, not only with their own patients, but with other providers or with other providers that service that patient. So it's very difficult, and patients can't easily organize, access, share, or share their health data. And again, similar to the corporate side, there's these large monolithic EMR systems that are being acquired by health systems, right? And the risk there is that a lot of these EMR companies, you know, it's a rip and replace, and they're somewhat monopolizing providers. Again, there's a lengthy implementation time frames and questionable ROI as far as that. On the national security side, you know, federal, state, thousands of federal, state, regional, and local government and public safety agencies today can gather and share critical information across a lot of different agencies, but also market segments. Right, so being able to pull information across a lot of different sources to help them identify and reduce threats. Right, compare that to the healthcare space today. Again, there's a lack of connecting different clinical, social, environmental factors that all help provide a better perspective of the patient. And if we had that information available, then again, it can help improve the ultimate outcomes of that patient. Right, also on the national security side, there's custom system-to-system interfaces, which, you know, the point-to-point interfaces, there's high development costs, maintenance, and time to build. They've been replaced, and they've been replaced with a standardized interfacing approach It's referred to as NEAM. And this standardized interface approach was designed to help reduce timeframes, costs, and promote high reuse and maintainability. Right. So again, a great lesson and a great model that we can follow as, again, here in the healthcare space, we're looking to make multiple EMR systems interoperable. Again, and in many cases, dealing with the same issues associated with point-to-point interfaces. Right, so again, there's been a lot of focus always on information sharing and interoperability. It's been proven successful in the financial services, corporate 100, national security space. And as we look to the healthcare space, we certainly can look at things that have worked and haven't worked and avoid some of the common pitfalls that we've seen. Okay, next I'm going to talk about the various modes of exchanging information and interoperability. Right, so one of the, I guess, the problems today is that there's a lot of different terms, and very often people use these terms interchangeably, where they're really very different. So information exchange and information interoperability and value-based care are sometimes often used meaning the same thing, but as I mentioned, it's very important for us to spend some time to understand really what are each of these and where do they fit. Right, so there is a path to data value-based care, and it does start with information exchange. But from information exchange, moving and migrating upwards in value to information interoperability, then actually enabling interoperable information. And I'll talk about the difference between those two. And ultimately, the goal for all this is, again, the triple aim, is how can we have data-driven insights to basically improve patient outcomes. Okay, so first we're going to talk about, again, information exchange. So the definition of information exchange is simply the electronic movement of health-related information among organizations according to nationally recognized standards. So it's actually the movement of health information, okay? Pros, obviously, is that it provides a key building block for improved patient care and facilitates the achievement of meaningful use requirements. Cons for information exchange is it in itself does not get us a true interoperability. Okay, so an example of that is if I send an email from one computer to another computer, I've exchanged information between those two systems. Right, if I write my message in French or in one language and the recipient of that message can't interpret it in French, okay, then we've exchanged information, but we can't, the receiving party can't use that information. Something is possible to be lost in that translation. Right, so again, exchanging information is simply the movement of information. And you know, one of the common examples today is the Direct project, where it's defined as secure HIPAA compliant email-based exchange, where you can push personal health information from one system to another. Right, so that is information exchange, is again just the electronic movement. How that differs from information interoperability is the ability for the two systems not only to exchange information, but to actually use that information, use the information that has been exchanged. Right, so information interoperability builds on that. And you know, the pros obviously again is provide the building block for improved patient care, but there's a fine line between information interoperability, the ability to share information, and actually enabling information sharing. Okay, and you know, one of the challenges with many information sharing projects is it's a cultural change. Right, what we're doing now with trying to break down the silos to share information to improve patient outcomes, in many cases, it's counter to what individual organizations have built businesses upon. And one of the sad things that we're seeing right now is that despite the fact that there's been so much attention and focus and funding available to help move the needle to more interoperable systems, now there's a lot of focus on information blocking, right? So, and again, it's expected, and we've seen this in all the industries we've been in, where again, it's a behavioral change that occurs. But over time, vendors, it's going to be harder and harder for vendors to basically compete based on holding data hostage. And there's going to be a turning point where, again, it's absolutely focused on making the data interoperable and competing on features and functions, right? But the sad truth is today it's still somewhat of a challenge, but it's available. So many of these EMR companies, they have the ability to exchange information in an interoperable manner. But what many users see is there's challenges associated with it, right? It might not be easily available. There might be costs available to it. Again, over time, that'll change. But that's fundamentally the difference between information interoperability, the ability to share information, and having interoperable information, which is the action of having systems exchange and use that information, right? And the action of interoperable information, there's several value-based care models that have evolved and with very proven, demonstrable outcomes. So the two most notably are patient-centered medical home and episode of care. I know Randy touched on both of those in his last presentation, right? Some of the negatives or cons at this point is that these models, these interoperable models, are still relatively new, so they're not yet widely implemented or adopted. But that is the goal. That is the future, is moving to these value-based care systems. So stakeholders face several challenges when operationalizing these models, and there's a need for better availability of resources, tools, and implementation methodologies. One note here is in Ohio, with the Ohio Health Transformation Strategy, the goal is to enroll 80 to 90% of all the state population, 10.1 million Americans, in one of these value-based models over the next 4 years. So this is where industry is moving towards, and we'll definitely get there. The question right now for many of you on the line is, are you going to be where are you going to be positioned in this transition? You can either be helping to lead the charge or take a wait-and-see type of attitude. Okay, and with these models, the value-based models and the various methods for exchanging information and making information interoperable, again, the ultimate goal is data-driven value-based care, right? So we hear a lot of things today. We hear things like population management. We hear things like care coordination and transition of care and patient engagement and patient-centered medical home and accountable care organizations, right? So there's a lot of terms being floated out there, and it's very easy to kind of focus on what do we need to do to satisfy this specific initiative, right? But one of the things that we need to urge is really take a step back to look at what the big picture is. And the big picture isn't how to implement things like population risk management independently. It's how do we take all of these initiatives and make them work in a coordinated, cohesive manner so that, again, improved outcomes will prevail. And each of these payment models and each of these approaches and initiatives, one thing they all have in common is it requires interoperability. It requires information sharing. Again, the last two presentations that were given over the last 2 weeks, both those points have been noted as well. Right, so from the quality standards and reporting aspect of it to the capturing the payment reform models, again, they ultimately rely on the ability to pull and share information across very different users and systems. So this is the ultimate goal, right? And with data-driven value-based care, it benefits all participants, right? It benefits the patient. It benefits everyone that patient touches during their journey. Okay, so again, interoperability is the key to value-based care. And without health data interoperability, there is no electronic path to patient transition of care. There is no health information exchange. There is no meaningful use of EHRs. And without interoperability, we'll probably never achieve, again, the ultimate goal of improving the patient outcomes and reducing the costs associated with healthcare. Right, so interoperability is absolutely key, and as such, again, everyone should really focus on what is our strategy for interoperability, right? Because it is key, taking a sit back and wait and hope, hope things work its way out, or having vendors promote that, it may not be the best strategy. Okay, so interoperability information for value-based care is much more than sharing information between EMR systems as well. So with value-based care, the challenge is there's multiple layers of interoperability. Often individuals talk about interoperability as building an interface between two different EMR systems. And the nice thing is that there's more standards that are available now to make that easier, right? So the continuity of care document, the direct standard for email exchange, secure, FHIR, all these technology standards are evolving to make it easier for systems to be interoperable. But the other layer of interoperability is provider interoperability, right? The fact that when you look at patient-centered care, a patient may interact with large, sophisticated hospitals with large, sophisticated EMR systems, but they also may have a dietitian or a chiropractor or a behavioral health therapist that may or may not have an EMR system, or they may have an EMR system, but they're still faxing information largely. Right, so being able to have interoperability between the levels of sophistication and the levels of technical readiness between providers is also something that is often overlooked, but it's very, very important. And then the third level of interoperability when we talk about value-based care is non-clinical information sets. Right, so there's more and more focus on not only being able to bring clinical information together, but being able to also tie in social and economic and other information sets that allow a provider to have a better perspective of the patient and be more prescriptive on their care plans. Right, so interoperability in value-based care is absolutely challenging. There isn't an easy way because, again, there's multiple layers of interoperability that's required as part of that. When you look at some of the roadmaps, right? So here, this is the Health IT Government Roadmap. This is, they're basically laying out where we are today and where we'll be going, right? And we can use this interoperability roadmap and as well as the state's interoperability roadmap as our guide, right? To see where are we and what can we be doing to help again be at the right place at the right time. Right, so this is a great graphic, again, published by Health IT Government. Some of the key points I just want to note here is that today there's still a large gap that exists between hospitals and office-based physicians that have an EHR or EMR system, and how many of those that have an EHR system are actually using it for information exchange and interoperability. Right, so in this case, 95% hospitals have an EMR, but 62% are actually exchanging information. 78% of office-based physician offices have an EMR, thanks to high tech and for the grants, yet 14% of them are interoperable. They're still relying heavily on paper. Right, so there's still a lot of work that has to get done to better leverage those EMRs. Another key point here is that within the next 2 to 3 years, that providers should have solutions to help overcome these speed bumps, right? These blockings of information sharing. So the good news is that, I mean, the reality is there's the obstacles. What we've learned from other industries is that there's always obstacles, but ultimately perception and changes. And in the government national security space, when we first started, the mentality was, I'll share this with individuals that need to know. And here we are 10, 15 years later, and now there's a responsibility to share. And over time, individuals and organizations, it'll be easier and more accepted to share information. Right, this graphic continues to talk about where are we going, and where are we going talks about, again, being able to look beyond just clinical data sets and look at other health determinants. And one of the interesting points is 80 to 90% of the health determinants are not related to healthcare. So the ability to look at, again, social and economic and environmental drivers and use that with the clinical information set to have a better perspective of that patient is absolutely where we're going. Right, and I love this term of the learning health system or care coordination system, right? And the fact there is that it's about connecting expanded data sets and information and care settings to basically have a continuous learning system that drives healthier people, smarter spending, and better care. So that's the national roadmap. Again, I think everyone can kind of determine where do we fit today, and where and what's our strategy to again help transition ourselves into this space. Another model we can look at is at the state level, right? So a lot of work and effort and planning has been done at the state level for their health information technology strategy and roadmap. And they've identified, again, very aggressive objectives. Again, transition 80–90% of the population to a value-based model over the next 4 years. But they've also identified, in order to do that, what do we need to address, right? So they've taken an inventory of what's required to make this transition from fragmented care, pay for service, to coordinated care, pay for value. And they've identified these as critical areas that decisions have to be made on, right? So in many of these decisions, when you look at care coordination, patient engagement, is are we going to build, are we going to buy, or are we going to partner with organizations to satisfy these? These requirements, again, are requirements to basically achieve value-based care. So it's really nice to have something like this where it's laid out, where individually you can take a look at this. Obviously, certain things you have less control over, like rewarding value. But what's nice to know is that this is where we're going to end up. And there's a lot of, the momentum is building to, again, have the proper incentives and aligned incentives and have performance transparency. And everything that you're seeing and we're all seeing around the move to value-based care is operationalizing these aspects of it. Right, so these are resources that I urge you to look at and review and use within your own organizations and practices. Okay, so that's where we are. That's where we want to go. How can we get there? What are the different approaches that we can focus in on? Right, and there's several of them here. I really wanted to focus on 3 interoperability approaches. The first approach is an EMR-focused approach, and you see that a lot today, where large vendors like Epic are gaining such an incredible market share with health systems. And in the EMR-focused interoperability approach, again, providers are standardizing on a common EMR, and then relying heavily on that EMR to provide the capabilities that's going to be required, as I showed in the previous slide, the requirements focused and required for value-based care. Right, so this is a popular approach right now, and the characteristics, again, there's a dominant EMR. Epic's probably the best example of that. And the approach for interoperability in many cases is rip and replace. Right, so you may be a provider that has a different system, but again, the goal is get on our EMR and make it easy to share information. So some considerations around that area, again, is number one is there's strong established vendor relationships, which are great, but you really need to weigh that against potential vendor lock-in, and this is largely a software license approach. Right, so these EMR-focused interoperability approaches, they're long, they're costly, there's a lot of training that has to get done, but this is a very common approach today, especially, again, Epic's probably the best example of that. Right, another interoperability approach is really the health information exchange focused approach, where states and organizations are standing up an exchange, a health information exchange, to satisfy moving information, value-based care capabilities. So here in Ohio, there's CliniSync, and OHIP is a common one, but we also have HealthBridge. Many states have HIEs and sometimes multiple HIEs. Characteristics of these HIEs, there's a wide variety of different approaches depending on the state on their health information exchange. Usually it's what we call the big data approach, right? So it's the fact that, you know, conceptually if we can get information into a common place, then the users and the participants can go there and gain access to as much of that information. So again, it's very much a big data approach. Let's get as much information as possible because we don't know what questions the users are going to have. And again, over the last 25 years, this has been a common approach for every industry. Let's build these large exchanges. Challenges associated with these efforts are that usually for these efforts, there's a lot of different participants that you want to get involved, and each participant has to adhere to a defined set of requirements, right? So here's technical guidance, here's technical requirements. All of you participants go back and meet those technical requirements, and once you can meet those technical requirements, then we can again enable information sharing, right? But in many cases, the burden is on the participants to meet those technical requirements, and again, this has been a very common approach over the last 25, 30 years, and the challenge with a lot of these is typically adoption, right? When I talk about the interoperability layer and the fact that you have providers that vary, some are large providers with the right resources, but you have a wide number of small to mid-sized providers that may not have the technical expertise or the financial resources or the time to basically meet these technical requirements, right? So adoption is jeopardized. So that's a common approach with many of these, what we call our big data or big bang or boil the ocean type of approaches is getting the adoption, especially for the small to mid-sized providers. And when we're talking about patient-centered care coordination, it's inevitable that you're going to be dealing with small to mid-sized providers, right? So that's the HIE-focused approach. A newer approach is around care coordination systems, right? So with the drive and the movement to value-based care and the focus on patient-centeredness and coordinating care between providers, again, there's new models and new systems being developed which, again, do not compete with EMRs and HIEs, but complement and fill the gaps of the EMRs and HIEs, right? So these care coordination systems understand that many providers have EMRs, have made large investments in EMRs, which are great, but the EMRs were largely built on providing and holding a lot of good data within the four walls of an organization. Right, it's very difficult and challenging to share information between EMR systems, and many of their businesses make it, it's counter with their business practices. In many cases, they're competing with other EMR companies. So again, we go back to that information roadblocking type of scenario. But these care coordination systems are evolving, and again, it's best of breed applications. It's being able to identify what's the best reporting application that meets my reporting requirements, what's the best patient engagement application that meets my patient engagement applications, how do I need to interface and interface all of these applications and the data that's generated from these applications with each other and with our EMR and with our patient and with the provider care team. Right, so it's more of a care coordination system, and there's a wide variety of the different types of those care coordination systems. Many of them are focused on specific points, like again, reporting or patient engagement, but they all need to rely on some mechanism for bringing data together and sharing information together. Okay. From an approach perspective, rather than having a big data approach, it's really what we call a small data approach. So it isn't about the amount of data and the volumes of data that are available. It's really it's breadth, not depth. It's being able to have the right information that allows a user, another provider, to know about the patient, your diagnosis, and your care plan. Right, so it's a very small, focused data approach versus a big data approach. And from a pricing perspective, usually those are more subscription-based models, taking advantage of some of the SaaS models and cloud-based models out there. Right, so there's a number of different companies emerging in these spaces and different approaches, and there's a lot of other interoperability approaches. These are probably the three most common that I wanted to address. Okay, so where do we go from here? Right, so here's some interoperability strategy recommendations that you can take and do with what you want with it. The first one is really anticipating where the puck is going. Right, so often there's this reactive approach to interoperability, right? I've got new requirements, meaningful use requirements, patient engagement objectives, quality metric requirements, and let me react. What do I need to do to meet this requirement? And guess what? Once you meet those requirements, there's going to be another set of requirements, right? So there's meaningful use 1, meaningful use 2, meaningful use 3, and on and on and on. Right, there's 5% patient engagement to ultimately we'll get to 80, 100% patient engagement. Right, incentives today there's increasing incentives and increasing penalties for to stay in the pay-for-service or move to value-based care. So I think one of the recommendations is anticipate where the puck is going. Don't build strategies based on where we are today. But again, look at the roadmap that we showed earlier, both at the state level and the national level, anticipate where they're going, what those requirements are, and what can you do individually to build an infrastructure that supports where you are today, but also allows you to grow with the future requirements. Right. Second recommendation is think big, but start small. Right. This is, as we talked about, this is a major undertaking, and it's a very, very complex. And there's so many different areas that you need to consider and focus in on, from interoperability to different users' readiness and sophistication to external data sources and partnerships, and there's so much to consider. So in many cases, it's overwhelming. Right? There's the term of you can't eat the elephant in one bite. Do one bite at a time. Again, that's the goal here is know where you want to end up, but start with the simplest solutions. What's the smallest thing that I can do, be successful on, that gets me one step closer, right? Third recommendation is build upon your existing infrastructure, right? You spent a lot of time and made a lot of investments already. You don't want to have to rip and replace, right? There's, again, we've seen many times where that's been the case, and the ROI, the return on investment, and the time to value is always questionable in those areas. So look at how you can build on top of what you already have. Account for participants' varying level of sophistication. We talked about that already. One size does not fit all. So to really benefit, you need to have a solution that addresses how you interact with large, sophisticated providers and sophisticated EMR systems, but you also need to have a strategy of how am I going to interact with a provider that doesn't even have an EMR, or a provider that's still largely faxing information back and forth, right? You can't expect someone that's faxing information to go from fax to predictive analytics. There has to be a crawl before you walk, before you run strategy. Leverage the market and take control, right? So again, taking control is a big thing. It's demand interoperability, right? You're the customer and demand interoperability from the vendors. And if you sense or see any roadblocks, don't accept it. There's a lot of value in being able to say, this is what I need, and I need you to provide this to me. And if you can't, then there's others that will, right? But I think that's the key, is take control. Take control. I mean, at the end of the day, it's your patient's data. You're the one that's really impacted the most, and it's your decision on what your what your interoperability strategy is. So take control. Last few recommendations: if you can, maintain modularity. Again, having independent components that can be connected together, right, allow you to ease your scale and be more resilient to change. right? So having a methodology where you can look at other applications and requirements and not have to totally overhaul your system, but you can take other point solutions and just bolt it on very much like a Lego block. Right, so modular systems are really a recommendation and the way to go. Last few, focus on value. Again, prioritize. Look at what small things can you do that would have big impact. Obviously, privacy and security are major areas that you have to and still spend a lot of time and effort on. Right, you have to have public trust and health information. Obviously, it has to be safe and secure. The good news is there's common practices and there's known techniques for this. Right, again, privacy and security of data, it's not new. It's been done, again, across a lot of different industries, and there's a lot of things to learn from. So, and don't use things like privacy and security and HIPAA as excuses for interoperability. We're starting to see that as well. It's really, HIPAA was designed to promote interoperability while protecting information. Last one is standard scalability and universal access. Again, the good news is there's a lot of momentum that makes it easier to overcome some of these challenges around interoperability. Right? There's committees and there's incentives and there's approaches that for, again, developing standard ways to interface systems, standard approaches for engaging patients. Again, there's a lot you can gain by looking at past successes and avoiding past pitfalls. And lastly, it's empowering individuals. Right? Technology itself is accelerating at just incredible growth rates, right? I mean, if you look at just the cell phone and the smartphone, and you look at your computer, and then look at everything around you, technology is advancing at such incredible rates right now, right? So again, when you look at anticipate where the puck is going, use technology to your benefit. Right, individuals today have smartphones, and they're using those phones for better access and consolidation of information. Your providers have, outside of their work area, they've got smartphones. They subscribe to social networks. They subscribe to things like LinkedIn. There's a lot of technology that today there's still a technology gap between what you do in your workplace and what's available from a technology side. So empowering individuals is about leveraging technology, right? Having mobile technology strategies. The technology is out there and it's real and it's useful. Looking at ways to apply that back into the space. So that is, I know we covered a lot of ground here. I wanted to leave, about 10, 15 minutes for questions at this point. So at this point, again, I want to thank everyone for attending. I'm going to open it up for questions. So if you do have a question, if you can send me a chat, and we'll address as many of these as we can. Also, if you'd rather send me a direct email or call me, my contact information is available here as well. Okay, so let's see. We have a number of questions. One question is, how do we pay for interfaces? Who should pay for the interfaces? So that's one question. There's a lot of different approaches for this. First one is there's a lot of grants that are now being made available to promote care coordination and the transition to value-based care. So there's a number of grants, both from organizations like CMS, as well as organizations like foundations and so forth. So a lot of them are out there. It might take some work and effort to basically mine for these opportunities, but again, there's a lot of grant assistance that's available because, again, everyone wants to move the needle to value-based care. So one thing is look at this. I know OECHC in their newsletters, they try to keep a pulse on what grants are available as well, and they push it out there. So one answer is look for grants. The other one is look at efficiencies, right? So in a lot of cases, what you're doing, what you're implementing, you need to drive operational efficiencies from that. And those efficiencies can be in the form of, you know what, I'm saving money, I'm improving my bottom line, or I'm increasing my top line because by investing in here, there's new financial incentives and rewards that are available to me. Right, and you need to really look at both of those areas, right? An example on the bottom line side is we were working with an FQHC where they were supporting, they had one EMR, but they had multiple reporting products and applications to support the various reporting requirements they had. And guess what? They're paying maintenance fees for each of those individual reporting tools. You know, when you talk about return on investment, it's about, you know, am I displacing costs, making it more efficient, and is there opportunities now to gain some financial rewards or incentives? And again, the good news is there's a lot of these incentives that are coming down the pike. Okay, another question is, when one interface partner upgrades the system, does that mandate changes for the other interfaces? And that's a great question. And when you look back at the government, my government example, and typically interfacing is thought of as point-to-point. I've got an Epic system that has to interface with a Cerner system, so I'm going to build an interface between Epic to Cerner, right? And the challenge with that is that those point-to-point interface approaches, you never get ahead of the game. Because number one, it takes a lot of time and effort and resources to know and map and build that translation and transformation delivery capability that the interfaces must have. And in the time it takes to build those, usually, as you mentioned, there's change. And with change, now you've got to, in many cases, rebuild that interface. So one approach to that from the playbook from the national security side is, it's referred to as NIEM, National Information Exchange Model. It is part of the White House information architecture, and the approach basically says decouple the interface, so it's not a point-to-point interface, and have one standard canonical standard that you map things into to and from. So rather than having an interface built between Epic and Cerner, you're mapping Epic to a canonical standard, and then you're mapping Cerner to a canonical standard. And you map that one time, and you can highly reuse that. So that approach of interfacing is available. It's largely used. It's commonly used, especially around national security, and it's something that I absolutely urge healthcare to take a look at. In fact, Health and Human Services has adopted NIEM as their standard, so I think we'll see that in due time. Okay. Another question is, the issue is so huge and the costs are so large. What have you seen in other industries, and where do we begin? Again, that's a big question. We could probably spend hours and hours on that. I try to highlight on my first slide things that have been done on the financial services side, in the Global 100 supply chain side, and national security side. So again, those models you can't follow. I think that I'd be happy to kind of address that more in person if you want to send me a direct email and direct question, because again, that would take quite a bit of time to talk about. Let's see. Another question is, with all the new HL7 standards, fire standards, will this help fix the problem? And yes, it absolutely helps. I think one of the things to understand is what they're addressed, what problem are they really trying to focus in on. So from a technical perspective, again, how you can enable direct, secure email. There's standards, direct is around that. How can you enable EMRs to have more of a query-based interoperability framework? The FHIR standards are being developed around that. The continuity of care document standard ways to describe a patient summary and transition of care. Those are there, and those are designed to help ease the transition from a technical perspective. But again, you have the other layers of interoperability that you need to focus in on at the same time. Question here is on empowering individuals. You talk about empowering individuals. Patients don't even use the portals. We're already providing them. And, again, one of the things we've seen is because of meaningful use, many of the EMR companies stand up a patient portal, and they make that available. One of the challenges, obviously, is that from a patient perspective, I may be a patient that has a chronically ill patient. I have multiple providers. They've all given me a patient portal, but there's no consistency on what they look and what's the amount of data that's available. So again, there tends to be this patient portal overload. Looking at approaches for unifying those portals into one. There's a lot of proven technologies and techniques out there. Again, we talked about things like Mint.com in the financial services world, where now users can basically configure and add their credentials to a single site, and it can pull information and scrape the data from those portals and provide it. So there's definitely many different approaches and technologies and techniques that are out there. It just takes a little bit of work and some guidance to help identify what's best suited for you. Okay, we're running out of time. So again, if you have any other questions, please feel free to either email me directly or give me a call. I really appreciate everyone's time today. Again, it was a great turnout, and this presentation is available both in the slides and the video itself. So everyone should receive a link to be able to download that information. Lastly, I'd like to thank again our sponsors, the Association of Community Health Centers, Insight, Cardinal Health, and United Healthcare for helping to promote and sponsor this webinar series. I'm hoping that everyone that participates is gaining value from this. And mark on your calendar now, next Tuesday from 9 to 10. This is going to be a very exciting webinar. I'm very excited to have Dr. Ted Winslow from the Association of Community Health Centers speak on patient engagement. So it's going to be, I'm sure it's going to be a very insightful and exciting presentation that I absolutely look forward to. So again, thank you everyone for your participation. I look forward to seeing everyone here next Tuesday with Dr. Ted Winslow, and we'll talk to you then. Thank you.